Hi everyone, welcome to our module on interstitial lung diseases. In this video, we're going to understand interstitial lung disorders, and I'd like to let you know that this is a very important topic because questions are rarely asked directly, but they usually require us to recognize patterns based on the clinical presentation, based on imaging, and based on physiology. So, if you understand the mechanism properly and try to differentiate between the different kinds of diseases, this becomes very easy. Before beginning with the video, I'd like to request all of you to subscribe and keep supporting. This lecture series is provided free and is open access for everyone. If you find it useful and wish to support its development, you can do so with the link that's on the screen and that's also pinned in the description. You can contribute to us with any of these payment methods. So, interstitial lung disease refers to a group of conditions that affects the supporting tissues of the lungs, specifically the area around the alveoli. So, these are also called as diffuse parenchymal lung diseases. So, this region is critical. This region around the lungs that supports it is really critical because it's where gas exchange actually happens. In these diseases, inflammation occurs in the interstitial space, and over time, this inflammation could lead to fibrosis, and this fibrosis could lead to scarring. Once fibrosis develops, the lungs become stiff and lose their ability to expand properly. So the core problem here in this condition is that that surface where the gas exchange occurs, this surface becomes abnormal. Now let's try to understand the physiology. So in interstitial lung disease, the lungs are stiff, so they cannot expand properly. So because of this, all the lung volumes are actually reduced. So this includes the total lung capacity, the functional residual capacity, and the residual volume. On spirometry, both the forced expiratory volume and forced vital capacity are decreased, but because they decrease proportionately, because this FeV1 and FVC decrease proportionately, their ratio remains normal or it's even slightly increased around the ratio greater than zero point 0.7. So this is a key difference that differentiates restrictive diseases from obstructive diseases. Clinically, patients usually present with progressive shortness of breath and a dry cough. So, on examination, we often hear fine crackles, which are described as Velcro like crackles because they resemble the sound of Velcro being pulled apart. So, whenever a Velcro is being pulled apart, so what kind of sound this makes? So, the same characteristic, a similar crackle is heard in cases of interstitial lung diseases. One of the most important diagnostic causes is reduced diffusion capacity. So this happens when the membrane through which the oxygen diffuses becomes thickened. So this could lead to fibrosis. So the disease usually starts with the repeated injury to the alveolar lining. So this triggers inflammation. So whenever there's release of inflammatory mediators, there's recruitment of immune cells that occurs, and normally this is followed by proper healing. And this healing, this repair process, is usually normal, but in these cases, this repair process is abnormal and this could lead to fibrosis. So instead of restoring a normal structure, the lung forms a scar structure or a scar tissue. So the key concept here is to remember that repair goes wrong. So instead of getting it replaced with a normal structure, what happens is there's replacement with a scar, there's replacement with fibrosis occurring. So as fibrosis develops, the walls of the alveoli become thickened and rigid. So this reduces the elasticity. The lungs now have increased elastic recoil, meaning that they tend to usually collapse inwards. There's increased elastic recoil and there's decreased compliance. At the same time, this decreased compliance, meaning more effort is required to expand the lungs. There's increased elastic recoil and decreased compliance. So this is why the patient feels breathless. They have to work harder to breathe. It's hard to expand the lungs. So oxygen transfer depends on how thin the alveolar membrane is. So in these diseases, the membrane becomes thick. So even if air reaches the alveoli, the oxygen cannot easily pass into the blood. there's reduced oxygen diffusion. This leads to uh, reduced DLCO, diffusing lung capacity of oxygen. So this is one of the most important tests though. So this DLCO is the most important test which is used to assess these conditions. Imaging plays a major role in diagnosis. So you often see a reticular pattern which looks like a network, and as the disease progresses, fibrosis becomes very, very prominent. So in advanced stages, you see something that's called as honeycombing. This refers to clustered cyst-like spaces that represent destroyed lung tissue. So this classic honeycomb-like lungs is the classic imaging finding that is seen in conditions of uh, uh, this interstitial lung disorders and pulmonary fibrosis. So now let's try to focus on one of the most important interstitial lung disease, the idiopathic pulmonary fibrosis. So this is a chronic progressive condition with no clearly identifiable cause. So it typically affects older individuals, especially smokers are most commonly affected. The disease progresses gradually, which could lead to worsening breathlessness over time, and there is slowly worsening breathlessness in these cases of idiopathic pulmonary fibrosis. The key mechanism here in this idiopathic pulmonary fibrosis is repeated injury to the lung lining. So instead of normal healing, what happens in these cases is abnormal repair and leading to the formation of a fibrotic scar. Fibroblasts become activated and start depositing collagen. So this leads to scar formation and distortion of the normal lung architecture. So again, the central idea in these cases of idiopathic pulmonary fibrosis is there's abnormal repair occurring that leads to fibrosis. The imaging findings are very characteristic. So you may see fibrosis mainly in the peripheral parts of the lung, and that's most commonly seen in the lower lobes. And the most important feature of all these is honeycombing. So honeycombing is characterized by clustered cystic spaces, as you can see in this image. So if you see this pattern in a right clinical context, so the diagnosis becomes very likely. Most commonly, it could be idiopathic pulmonary fibrosis. On histology, the disease shows a pattern called as the usual interstitial pneumonia. So the key feature in this usual interstitial pneumonia is the patchy fibrosis. So some areas of the lung usually look normal, while the others are severely fibrotic. So this variation in different areas is called as temporal heterogeneity. So under a microscope, when we try to understand it histologically, the most characteristic feature is patchy fibrosis, and this is called as the usual interstitial pneumonia pattern. Now let's move to sarcoidosis. So this sarcoidosis is a systemic disease, meaning that it affects multiple organs. So the hallmark of this is formation of granulomas. These are organized collections of immune cells, and unlike infections like tuberculosis, so these granulomas usually don't have a central necrosis. So these are non-caseating granulomas. So that's the key feature of cases of sarcoidosis. It is most more commonly seen in females, especially in African American populations. In sarcoidosis, the granulomas are non-caseating, meaning that they do not contain dead tissue at the center. So this is an important distinction from tuberculosis, where the granulomas are usually caseating in cases of tuberculosis, as you can see in the image, whereas in sarcoidosis, there's non-caseating granulomas. There's no presence of central necrosis. In addition to lung involvement, sarcoidosis has several systemic features. So there are specific inclusions that are seen inside granulomas, and certain enzyme levels are usually elevated. So patients may have joint symptoms, high calcium levels, eye involvement, skin lesions, and gland involvement. So you can remember the associations of the sarcoids using the mnemonic SARCOIDS itself. So S stands for Schumann bodies or satellite inclusions. A stands for elevated ACE levels. R stands for rheumatoid-like joint symptoms. C stands for increased calcium levels, which is due to vitamin D activation, and this is usually parathyroid hormone independent. O stands for ocular involvement, most commonly uveitis. I stands for interstitial lung disease. D stands for dyspnea and skin lesions, and S stands for salivary or lacrimal gland involvement. One of the most classic findings in the imaging of sarcoidosis is that there are lymph nodes near the lungs. There's characteristic bilateral hilar lymphadenopathy on imaging in cases of sarcoidosis. So this finding is very characteristic and is commonly tested in exams. The bilateral hilar lymphadenopathy is mostly associated with sarcoidosis. In laboratory tests, certain enzyme levels were elevated due to increased immune activity. So, calcium levels may also be elevated because activated immune cells increase vitamin D activity. In lung fluid analysis, there is an increased ratio of helper T cells uh, compared to suppressor T cells. There's increased CD4 to CD8 ratio. This reflects immune activation, and this is important for diagnosis support. Now we move into occupational lung diseases. They occur due to inhalation of inorganic dust over long periods, and the key concept here is the exposure of occupational dust-related exposure. So different exposures could lead to different patterns of lung diseases, and examples could include asbestosis, silicosis, coal workers pneumoconiosis, and work environment may indicate a particular lung pattern. Asbestosis occurs due to exposure to asbestos, which is commonly seen in construction or shipbuilding. It primarily affects the lower parts of the lungs or the lower lobes, and we often see plaques on pleura. So there's pleural involvement, and the classic findings in cases of asbestosis includes calcified pleural plaques, and also there are characteristic asbestos bodies which are golden brown rods that are seen in cases of asbestosis. There is also increased risk of lung cancer. So asbestosis carries a highest risk for bronchogenic carcinoma, whereas for malignant mesothelioma, it's the asbestosis. The second most common cancer is mesothelioma, but with regards to mesothelioma, the most common cause that's more specific to mesothelioma is asbestosis. So, silicosis occurs in patients who are exposed to silica, such as in cases of mining and sandblasting. So, this silicosis usually affects the upper lobes of the lung, and this is characterized by upper lobe fibrosis. And a classic finding that we can see in cases of silicosis is the eggshell calcification of lymph nodes. Uh, there's impaired macrophage functioning in cases of silicosis, and another important point is that it increases the risk of tuberculosis because it impairs the immune function. So, coal workers pneumoconiosis is caused by inhalation of coal dust, and this is also called as black lung disease. So, over time, this leads to inflammation and fibrosis, where carbon accumulates in the macrophages, and this accumulation would eventually lead to inflammation and fibrosis. In advanced stages, it can become progressive, and it can also lead to a severe condition of fibrosis. So now let's try to compare all these three occupational conditions. So this is where pattern recognition becomes highly important. Asbestosis exposure usually affects the lower lobes. So you can also remember it like, so asbestosis is mostly related to the roofing and construction activity where roofs are laid. So asbestosis mainly affects the lower lobes, even though it's from the roof. Whereas silica and coal, usually they are from the ground, and but this usually affects the upper lobes or the roof. Roof affects the base, and the ground affects the roof. The key feature in cases of asbestosis is pleural plaques, whereas in silicosis it's eggshell calcification, and in coal workers pneumoconiosis it's carbon deposition in the macrophages. Asbestosis carries a highest risk of lung cancer, whereas silicosis could eventually lead to tuberculosis because of increased susceptibility to infection, and cold workers' pneumoconiosis could lead to progressive inflammation and injury, which would eventually lead to fibrosis. So to differentiate these conditions, we always need to think systematically. So the first thing is like we need to think about who's the patient. So the other thing is that we need to understand about what's the exposure and what does the imaging show and what are the key associations. So if we follow this approach of first patient, then the exposure, then the imaging, and then the key associations, we can easily arrive at the correct diagnosis. So to summarize, so interstitial lung diseases usually cause stiff lungs and reduced lung volumes. So the lung volumes are reduced, but the ratio of forced expiratory volume in 1 second to forced vital capacity is normal or increased. Whereas diffusion capacity is reduced because the alveolar membrane is thickened. Idiopathic pulmonary fibrosis presents with honeycombing and shows the usual interstitial pneumonia pattern on histology. Sarcoidosis presents with non-caseating granulomas and bilateral hilar lymphadenopathy along with systemic features. Pneumoconiosis depends on occupational exposure. Asbestosis affects the lower lobes, whereas silica and coal dust affects the upper lobes. So the key to solving all these questions is pattern recognition. So we should follow a stepwise approach. First thing is who's the patient, whether male or female, what's his or her age, and the second thing is that we need to think about what's the kind of exposure is being exposed to. So what's the triggering exposure factor that could be a reason. And the third thing is what's seen on imaging. So what kind of lung involvement is seen, whether the upper lobes are more commonly involved or whether the lower lobes are more commonly involved. Or we've also discussed in cases of sarcoidosis, there is bilateral hilar lymphadenopathy. In case of silicosis, there is eggshell calcification of the lung. So each different kind of condition has a different imaging pattern. So we need to remember those patterns for sure. And the fourth thing that we need to think about is key associations. So whenever sarcoidosis could be asked, so this is not just asked as an isolated lung entity. So this could be associated with other common systemic conditions that we have already discussed. So the pneumonic that we have discussed, the sarcoids pneumonic. So this sarcoidosis usually affected with different kinds of conditions in our body, different organs. So we need to try to understand and try to remember those key associations. And whenever there's a question being asked, first the patient, the exposure, then the imaging, and finally the associations. So when we follow the stepwise approach, we can definitely solve all the questions. I hope this video helped you. Till then, I'd like to request all of you to subscribe and keep supporting. I'll be right back with another video. Thank you so much. Bye.